seen before. This is, let's see what you think.
That's ATFL, isn't it?
Yeah,
Yeah.
what's that in ATFL?
Wow, that's interesting. Some line of hyperechoic. Yeah, like right there. I that looks like it's on the capsular side.
Yeah, but what's this here?
A cyst of some sort.
Yeah, it's like a almost like a blistering of the ligament.
Yeah. Do you think that's synovial fluid from the capsule that's come through?
Yeah, something like that, or just an injury. But if you pull it back, let me pull it back. Look through there. There might be a
Yeah.
little
That.
tear coming through up somewhere there. Bit of breakdown in thing. I think it's torn. It's a bit of fluid broken into it. Some or just literally a blister. A ganglion or a cyst forming up in the ligament there. But whatever it is, just interesting. It was symptomatic. Uh,
Well, it was symptomatic. To touch or the ankle itself was painful.
I think it was tender around there, and they twisted their ankle, which is why I was looking at it. If my memory is good, this is just a pretty straightforward supraspinatus tear. But what's probably nice, what I liked about it, which is why I saved the clip, is the way. Hopefully, you can see the infraspinatus tendon here just coming across and showing you that the tear is in that bit of supraspinatus at the back of supraspinatus, the bit that gets covered by infraspinatus. So this is infraspinatus coming in obliquely here, that triangle there. So we can pan through that. Those are sort of essentially short axis fibers of infraspinatus. And this is the defect in supraspinatus.
Boy, more than just showing a lesion within the supraspinatus, that helps to better identify the tract or the trajectory
Yeah,
of infraspinatus
yeah,
and supraspinatus.
yeah. So you can see the infraspinatus fibers just running out of juice there. They're finishing inserting there. And you come back and you can just see the breakdown of the supraspinatus elements and possibly a little bit of a tear into the infraspinatus. I just thought that was a nice clip. And then you go closer to the front of the tendon, you can probably see some intact tissue here. So that's the anterior portion of supraspinatus there, and then the tear in the back of it. So I thought those were a couple of nice clips. And then you go back to here. This was, I get hips through that where the x-ray has said the arthritis is mild. And yet I see quite a lot going in at the inferior border of the femoral head. And these are often quite symptomatic, particularly into flexion. You get this.
Yes.
I don't know whether you got the geography on that, because it's not the best clip in the world.
This is
Quite,
where the femoral head starts to come
yeah,
down to the neck.
yeah. So
And,
this is the head, and then it's
yes,
there. Normally, you get a nice smooth curve,
yes.
roll off and down onto the neck. Well, here this is all osteophyte. When I see this subjectively, I would say these are the patients that sometimes they're all right when they're standing. Yeah, not always, not necessarily this one. This was clinically severe, but mild OA on the X-ray. So because the ball looks all right, but what you get as soon as they have to flex their knees, so if they're driving a car or if they're sitting down for a meal or they're squatting down, then they get a lot of pain because, and you can imagine this is running up and bashing against the acetabulum, and
Yeah.
you get this sharp sort of lipping appearance, a bit like you do on your OA of the hallux. The hallux OA, you often get those big osteophytes there.
And I think you were also telling me that you have added the inferior imaging of the the humeral head, and you can see sometimes the bulges of the osteophytes there, but not as sharp.
No, sometimes it's sharp. Some definitely we see that quite a lot. If I go glenohumeral joint OA, let me just make this bigger. Okay.
Do you think that these head of the femur osteophytes are secondary to some compressional irritation from FAI, like pincer impact?
I would be talking out of my six if I made any thing there. I don't see this population clinically. They come to me in the scan thing when they've already got to this point.
Gotcha.
So I'm not seeing these people year in year out, and seeing it develop. So I just get these guys as a snapshot. So yes, sometimes they come when and they've said, oh, this is a pincer on X-ray. So or even sometimes MR, mild OA and pincer, and then I look at them and I think, this is what I'm getting, and it's early osteophyte to me all day. But I'm not really the one to judge. I will stick a needle in it, or I will send them off to the surgeons.
Is that what this got? This was a epidural steroid within hip for pain?
This would probably be me turning around to them and saying, actually, I think there's a bit more going on than the guys who saw you, because they'll have seen someone else. They'll have looked at the X-ray. They'll have said, "Oh, you're in quite a lot of pain," but your X-ray is saying you've only got mild osteoarthritis, so we should try an injection. And I will go to them. If you're having a rubbish time with this, a really bad, lots of symptoms, clinically severe, then I think the X-ray is undercalling it, and you should probably be going to see a surgeon. And then they may persuade me to do an injection, and I will say, do this. It has some downsides to it, and you can try and see if it works. But I think this is where you're heading. And the patients, as often as not, will say, well, actually, that's where I feel I'm heading. And then they go off and see the surgeons.
With an injection to this, because it seems like it's more of, like you said, in standing, many times they can tolerate the loading.
Yeah.
An injection, if they talk you into it, is sold with this. I don't think it's going to be much helpful. Or do you think that because of the irritation, there could be some improvement with some?
We get quite good results, and now we use something called an Oxford score, or I use something called an Oxford score, which is one of these measures, and I find that if they have an Oxford score in the region of 25, then I think they will often get some benefit. That's not specific to this appearance, but it's when the symptoms are not too severe, they can still walk to the shops, they can still get a reasonable light sleep most of the time, even if they get some disturbance. But they're not hobbling into the department and hobbling into my room. And then when they do that, then I say, for some of those patients, they do really well with injections, and they get quite a long period of relief. But as soon as the symptoms become a little bit more, much more down to what we call a level around the 20 score on the Oxford scale, then they're struggling at night, they're struggling to get up out of a chair, they're struggling to get into a car, and those sorts of things, and always getting pain at night and quite severe pain. Then I'm of a mind that an injection does very little good, and that's what, looking back at our cases when my colleagues have done audits on it, we get poor results with the injection, and it has probably a slight negative effect on the risk factors at surgery. There's some debate about that, but there's some evidence for that, and so we tend to think we're going to get a poor result. You're going to get 2 weeks benefit at most from the injection, and then you're going to be left with a worse hit because of the steroid. So we should really be moving you on.
Do you do visco supplements? Do you do?
I don't know, except very occasionally, but because they're not funded by the health service.
Okay.
So I do steroids. I think there's a good argument for them. I think if I was seeing someone privately, and I don't really do that, but I would probably be trying that if they were determined. But there's I'm not I just don't. It's not part of my practice, but it would be if I was advising people where they could pay for it. There's merit in it. It carries risks like anything else, but that there isn't the detrimental effect that you get from the steroid. So it's a punt with less of a downside.
Right.
Yeah. I've got another hip, I think, lined up for you. Not now, but in a moment. Idiopathic. This is again something I've shown you times before, and I'm sure you see a fair amount of. But this is infraspinatus, looking a little bit moth-eaten. So the tendon is intact, but when we come out, the muscle is rubbish. And if you compare that to healthy looking teres minor.
Yes.
And so this is part, along with looking at the inferior capsule, looking at the muscles is part of my standard routine on every shoulder now. Just because it's not always that straightforward to do. And so if you do it all the time, then you get quite practiced at just swinging down through the muscles, and it takes a second.
So let's apply this clinically. Where do you go in your mind? Are you saying this is neurogenic? If you see a quality tendon and that happening, or is this just...
Yep. Basically, the vast majority of times you see it in inflammation, it's second to a tear. And then it colors what you think, particularly if I'm going to be talking to them about whether they need surgery or not. Then if they have severe wasting in the infraspinatus, whether the tendon's intact or torn, then I'm thinking this is chronic. The changes are chronic. The surgeon's less likely to consider a cuff repair. And if you are going to surgery, they're going to be thinking more about a total shoulder replacement, which is a much more popular thing now than it used to be. If they're young and they have a good, much rarer presentation, but if they're young and they have good-looking tendons, and then you see that, then you're in what we call Parsonage-Turner syndrome, where you've had a brachial neuritis of some sort, and they're quite good to pick up because those patients just don't know what's going on. They've got a shoulder that doesn't work, and and you can pat them on the head and say, you're going to get better in 18 months. You're going to feel much better about this, and it's going to stop hurting relatively soon when you stop trying to do what you were trying to do. All that therapy.
That poke to the pig, yeah.
So you're looking for that. You're looking for the very rare occasions when you get, I think they call it quadrilateral space syndrome, where you get irritation of the nerve affecting the teres minor. To be honest, you will see wasting of the teres minor, selective wasting of the teres minor, many, many times for every case that you see that's actually a quadrilateral space thing. It's an idiopathic thing that shows up reasonably regularly when you look for it.
And we don't know why.
You could probably make a fair guess that in the course of life you manage to injure the nerve at some stage, but for a lot of patients it doesn't really cause much of a problem.
Yeah. It's such a small thing. It makes you think we're talking popliteus or plantaris or anconeus or some of these things that we just go, what in the world are you there for?
Yeah, well, I don't. You wonder that, but it's a big old muscle in a lot of patients.
You mean the teres minor?
Yeah, teres minor. There's nothing very minor about it. It's a good sized muscle. it's there's nothing. There's but it doesn't really. It's not really part of the rotator cuff. It doesn't really attach. When you look closely at where the fibers go, they're quite a long way down on the back of that greater trochanter. They're quite a long way down. They're not really covering the humeral head at all. They're whisking down below the. They probably they do brush over the inferior part of the capsule, but it's not. They're not really inserting round onto the posterior facet.
So are you thinking more that it would be more of a shoulder depressor, more like pecs, teres major?
I wouldn't even say that. I would say it's very much a supportive role.
Yeah.
It's probably much more about movement than about stability.
Yeah.
I think.
Yeah. Fascinating.
That would be my take on it. Let's have a look at what else we've got. I had to look at this twice because I didn't read what it was before I saw what it was that I'd captured. So
this was dorsal hand?
This is ventral hand. This is palmar hand. So let's just run that through again, see what you think. Go on, let's run it again. This is the hand. And these are the flexor. It's a big old effusion. You take it back.
Within the tunnel.
Yeah, or certainly in the forearm, tracking down towards the tunnel. Yeah.
Oh.
In the tunnel, there's a bit going on there, and then there's a bit of fluid. So in the tunnel itself, there's actually no fluid at all, or very little.
I see that.
Just see it pushed distally and proximally. And this is something I come across not infrequently. This will show up, probably 2 or 3 times a year for me. So it's not common.
It's free fluid that is surrounding the myotendinous junction of finger flexors.
Yeah.
Why? Overuse?
It can be inflammatory arthropathy usually, or it can be. I've seen it in old ladies who've broken their wrists, things like that. Just. But I can't say that there's one thing that strikes me that causes it. But yeah, that's the classic.
What is their subjective report of pain? Is it like stiffness with movement? Sometimes
it's just they got sore wrist and they don't really know why, and they got this swelling.
Go ahead.
No, I wasn't.
How would you narrate this pathology?
I would if I was this was a patient who I saw in clinic, so I would have I wouldn't have had to narrate very much. This is something I would have just put a needle in and sucked the stuff out, and maybe dropped a bit of steroid in there to see how it went.
But if you would expect them to be quite pain improved directly.
Yeah.
Yeah, and you were about ready to describe this.
The shower room is actually off his bedroom, so.
Oh, very nice. So they have to wait for him.
Yes.
They go through my room.
Alex, can you run upstairs, please? Yeah, that's fine. Go on, off you go. Yeah. Come on, quick as a flash. We've got to.
Where is my mama?
What
it was quiet. It won't be.
That's okay. Thank you for even just giving me a little bit of time.
That's all right.
Who are you taking with you?
I'm taking the oldest and the number 3. Number 1 and number 3 are going.
Okay.
And so we just thought it would be nice just to have a little quiet time with less of them.
Yes.
Before they all go back to school.
So it's just you and them?
Me and them, and Christine will stay back with the other 2.
Okay, very good. Well, run it through again for me. I clearly can see a pocket of fluid. Are we on dorsal foot, or where are we?
We're plantar foot, I think.
Plantar foot.
This here is the peroneus longus.
Okay.
So that's the peroneus longus tendon crossing the foot, and there's a little ganglion arising from one of the joints. Don't really usually spend very much time looking at the plantar aspect of the tarsals and tarsometatarsal joints. But,
what made you think of it? I'm trying to think. How close are we there to the Henry? Is that's on the other side?
A little way from the Henry. This is more on the lateral side of the and more distal. This is around the things. This is. Do you scan peroneus longus in the plantar foot?
I don't as a rule, but I don't get a lot of these, and I have just recently. Again, I've been going through a lot of these Con Ed things to get my number of hours up for the 3-year certification. So I have looked at it in the last 3 months. So, but before that, I bet it was a year.
Yeah, we never looked at it very, very often, but I try just to when I'm scanning this past the foot, just because it's quite a tricky thing to scan.
Yes,
and so again, it's on my list of things I always look at because when I need to look at it, I don't want it to take forever to find it.
Yeah, see, so that's it. See, not only do you have the repetitions, but you have the professional morals of actually keeping your skills up.
Well, the problem is that because I do quite a lot of teaching, the students are asking me, and I just don't want to look an idiot. That's what it's personal shame that makes most of us good.
I'm looking at teres minor here and another infraspinatus.
Yeah. And the teres minor this time is the one that's atrophied.
Ah. What is that one? Is that the contralateral side?
That's a good one. That's a good one. That's on the other side.
Okay.
On this side, that must be infraspinatus, and that's teres minor.
And this was again a non. This was just a find.
Not convincingly. Say infraspinatus, tendon intact, and then there's the teres minor, but not a convincing posterior shoulder pain patient.
Let me ask you this: if we took the cross-sectional area of the contractile muscle of both of those, the combined contractile muscle of the cross-sectional area, would you say that there was a compensatory equalization with teres minor being atrophied and a larger belly of infraspinatus?
I don't think you could say that way around. You certainly could say that the other way around.
That the teres minor goes up when infraspinatus goes wimpy.
Yeah, not in every case, but but in quite a lot of times you look at it and you go, oh, infraspinatus is really wasted. Oh, teres minor is
how brilliant! That's fabulous. That's what you'd like to say from a well-run machine.
Yes, that. So this is just an odd case.
This looks like a finger flexor where the chiasm of Camphor has the profundus and superficialis coming through.
Yeah.
But is a nodule within the superficialis?
No, within the deep one.
Oh, the profundus.
Yeah, nodule in the profundus that is causing scalloping of the proximal phalanx.
Scalloping is a periosteal term.
I think so. Yeah.
Yeah, I'm just
call it just where it's taken that where it's and I sent this for MRI because I just thought why is this thing causing that change? But apparently it's just eaten away at the bones.
Wow.
No. Okay, go on then. Yeah. But yeah,
there...
so I don't know why that's happened, but I got an MRI of it to try to make sense of it, and it is just the tendon is thickened there, and then the what's the name has changed. The bone has sort of just been eaten away essentially, and changed shape.
Were you concerned for some neoplasm or some cancerous type of a process going?
Not necessarily cancerous, but certainly that is a process that occurs with you get it with giant cell tumors, which is a common non-cancerous tumor in the hand. But you also get but also with malignancies and things. This didn't look like a malignancy, but equally it didn't look particularly normal. So I got an MRI just as a sort of safety measure, and to try and see what was going on there.
Is there not? It seems like a pathognomonic condition for a rheumatoid issues where they talk